My name is Paul Sidi. We're in days of lockdown. We've still got to be careful. Well, we can't really treat people unless it's an emergency situation. So I've got all my gear here. Now, I don't need to wear this. It's really just to point out that if anybody has a problem with, or just to understand that we will have a model in here who actually is my wife. There's no social distancing problems, and it will just help with showing you how we use the machine. And so don't worry about me causing any social distancing problems. I would also have all my gear on if I was treating anybody in an emergency situation. So welcome to this little talk on, as Phoebe said, ankle tendonitis. Well, to be perfectly honest, it's not really about ankle tendonitis. It's about ankle problems involving the tendon. And most of those problems will generally be a tendinosis. I suppose what we need to just quickly address, very quickly, is anatomy and the definition. Well, your Achilles tendon, the heaviest weight-bearing tendon in the body, it has two joining muscles to it, the soleus and the gastrocnemius, the two big plant flexors, and it attaches onto the bottom of the calcaneus. Now, this is all stuff which you know anyway. But what we must understand is it an itis or an otis, an osis, a tendonitis or a tendinosis? Because it will actually affect our treatment parameters to a certain extent. So as long as we understand that a tendonitis is generally just an acute inflammation of the area caused by micro tears, and it's generally from an activity. You know, you'll get the person who goes out, does the run, and they feel a pain. They can actually feel a little snap suddenly, and the pain goes on from there. But in most cases, in most people you will see, you'll be seeing a tendinosis, which is basically chronic degeneration of this tendon, which has these two muscles going into. Now, obviously that means there's a different thing going on here. In an itis, which refers really to an inflammation, you've got an acute pathology, you've got a little micro tear, there is huge amounts of chemical mediators, the inflammatory mediators, and that is primarily what we're going to be trying to sort out with the MLS in that situation. In a tendinosis, with the chronic degeneration, and just to point out as well, something very important to know, all research shows that in a vast amount of cases of what is a tendonitis, in fact, it's secondary to a tendinosis which hadn't been causing any symptoms to them. So they've got a degeneration of this tendon anyway, then they've got the little tear on there. So you've got a double whammy going on here with a little bit of inflammation as well as the chronic degeneration of the tendon. What we've got to look at is how we're going to treat these two things, the tendonitis and the tendinosis. Basically, with the tendonitis, we're looking to try and decrease the inflammation with the laser and repair the microtrauma. With a tendinosis, we are trying to create a collagen synthesis, and we have a machine here which will help with that. But can I just make another very important point? I don't think there's any machine available which can sort a problem out completely. The manufacturers of Acer laser wouldn't like me saying this, but it's 100% true. So what I always look at this fabulous machine as an adjunct, and there are so many adjuncts we can have, but you need, if you're going to spend a lot of money, if you're going to have an adjunct, you want one which works. And the science is behind this, and we can actually look very briefly into that. And if we need much more detail about that, we can get that from Celtic. But very simply, the laser is working, by sending photobiomodulation laser light in deep into the tissues, 5-6 centimeters. It's sending in 2 widths at the same time. Actually, I'll come back. We'll go through a few slides from ASA and go through that. Just on the pathophysiology, a tendinosis, much more likely to be seen in the older population as these collagen fibrils have degenerated. The itis, a straightforward tendonitis, usually a younger person, the weekend warrior, the runner, causing little problems. What I think we need to do before we go on to the slides is just consider, because the slides are going to show you what the laser is going to do, but let's just consider very briefly about what is the tendinosis and the tendinitis and the difference. But really, the tendinosis, which we sort of feel is usually behind any tendinitis as well. What is going on? Well, your collagen, load-bearing collagen, should be aligned for its tensile strength, like this, okay? What happens is, when we get a tear, we actually break it up, okay? And then there'll be a repair process. In a tendinitis, you'll get inflammatory mediators in there, and they will start actually just trying to repair the tissue. But what we need to do is look at how to actually do something about this. And probably the most effective treatment we can do as physios or podiatrists is actually do an eccentric loading program. Now, what's happening is, with the collagen repairing like this in a haphazard fashion and becoming more degenerate, and the collagen is also changing from an elasticized type 1 collagen to a very brittle type 3 collagen, just by not being repaired correctly. You have this, so then you do more runs, and this is doesn't have the tensile strength, will break again, more repairs, and this is how it goes on till it becomes a full tendinosis where the thing is all over the place. You get a massive swelling or edema around the area, incredibly painful to touch, and is pretty much painful most of the time. Just to briefly touch on the eccentric loading, which I'll just get my model to show very quickly. The eccentric loading, as all done by, worked out by Håkan Alfredsson, the Norwegian wizard. Eccentric loading is we are loading those muscles, the gastrocnemius and soleus, as they're getting longer, not shorter. So what is the effect on here? Very simply, by loading it, we're actually taking the collagen and we're pulling it elongated like that, okay? But there's much more going on, because I did a bit of artwork before, so no massive stuff here. Here we have a good tendon, and you can probably see on here, I've lost my pen, but I'll show you. We've got the aligned collagen, and we've got the tendon cells, the tenocytes. Long, thin cells, drawn a little nucleus in there, and that's how the tendon should look. What's happened is, when you've had the tendinitis and is morphed into a tendinosis, is this. Let's bring this down a bit. Where it has become much enlarged, okay? You can probably see the collagen is all laid down in a haphazard fashion. But here is the big problem. If you did a biopsy on one of these things, you wouldn't really see too many prostaglandins. They would not be there, because there's not an inflammatory situation going on here, but we've got huge amounts of pain. What's happened is, as the neovascularization has occurred to try and repair this, the cells have changed. These tenocytes, these long, thin cells, have become big and round, okay? The collagen's all been laid down in a haphazard fashion. There's scar tissue in there. There's all sorts of rubbish in there. And you can probably see I drew some little lines on here. That is what we term the cytoskeleton. The cytoskeleton, that is the framework which is keeping that cell all big and round. Okay, by doing the eccentric loading, we start pulling the collagen in the fashion as it should be, but something much more amazing happens. And Håkan Alfredsson, brilliant that he is, he cannot actually show exactly what's totally occurring, why the pain goes, because pain is coming largely from a neural ingrowth. what happens with the eccentric loading, we start putting the collagen in an elongated fashion, but that starts activating these proteins called integrins, which start slapping between the cells and the collagen and back to the cells and collagen, and they start knocking these cytoskeletons. These cytoskeletons are knocked, and they actually stimulate the nucleus. The nucleus then starts a protein synthesis, which actually remodels it back to here. Now, the big problem with a tendinosis, it can take a long time to actually really sort out. We normally look at an eccentric loading program of at least 8 to 10 weeks, and a huge amount of eccentric loading, 3 lots of 15, 3 times a day. And we do that with the knee bent as well as the knee extended, because we want to work on both the soleus and the gastrocnemius. So that is why we do it. I'm sorry to go on so long about that, but I think it's very important, because that is an integral part of actually, with a real problem like a tendinosis, is actually using that alongside the MLS laser. And the differences then you will get are absolutely fantastic, because when you're starting that eccentric loading, you're also starting a new inflammatory process, because you're breaking this tissue. So you'll get a new inflammatory process on top of the neural ingrowth, double whammy of pain. We've got the laser, we can reduce the pain massively at the same time as regenerating the tissues by pouring in ATP into the tenocytes, which are the real cells which we're trying to sort out. That starts a regeneration of them, a natural repair process, and we can speed this whole process up massively. So, just to very quickly go on to the eccentric loading, I'll get my model over here. You should all know this, but it's so important to make sure you do it both ways. Let's go here. Come across, no, down here. Okay, right, now, get your patient to stand up on the step, okay? Let's say it's her left ankle, which is the problem. I'm just going to bring this down here so we can see the left ankle. Okay. Now ask them to come up on their right foot, which is the non-injured one. So go on your tippy toes on the right foot, right up. Right, bring your left foot down onto that step in tippy toes. Bring just a little bit further back that foot. Okay. And then take all the weight on the left foot and then slowly come down. Now do this with the legs straight. 3 lots of 15. Okay. Don't come up on it, because that's shortening it. So bring your right leg back in there, come up on your right leg, okay, across onto the left, weight onto the left, and slowly down. Now we do that with the straight leg, we also do it with the knee bent. So up on the right, bend the knee, okay, left foot in there, take the weight on there, and then slowly coming down, okay. And you'll feel much more tension now, because we're working on the soleus lower down here. Remember, both this thing and this thing, big muscles, carrying the whole body. You've got to do the correct exercise. So if you want to go back and sit down. So, 3, 2, 1, back in the room. Okay. I'm just going to go through a few slides from Asa about the laser. If I can get this up here. And hopefully you can all see this. Sorry about the stuff at the top, but I haven't got on a PDF. MLS laser therapy, it says in podiatry, but it's any situation. Nice little pictures using a laser. I'm going to come down here. Now, please forgive this a little bit, because it's manufactured in Italy, and they sent me this, and it's a little bit Italianized. They go, the synchronization of the emission components is realized through a specific control system, the multi-wave lock system. It permits to modulate the emission features in order to perform the MLS laser therapy according to the different needs. Right, what that means in English is this is a unique system. This is sending in 2 widths of light at exactly the same time. No other laser can do this. What we know, or what we've known for years and years with laser, is if you send in a continuous wave, you can actually work on some tissue repair. With the old 3B lasers, you couldn't get the depth or anything like that. And we know with pulsed, we could actually work on reduction of pain. What lasers nowadays are doing is they are sending these different widths of light, but consecutively. So 1, 2, 3, 4, 1, 2, 3, like that. So you're not getting the same effect at the same time. Now, what's happening here with this MLS laser is pretty phenomenal. It actually sends in a frequency or continuous pulse at 808 nanometers, okay, at exactly the same time as it's sending in this super pulse 905 nanometers. The 808 nanometers works really on tissue repair and reduction of inflammation. It does that by creating the ATP, forcing that into the cells, and it also gets the NR10 protein to bind onto the inflammatory mediators, which cancel them out. So you're getting regeneration of tissues, and you're getting reduction of inflammation all at the same time, okay? However, you're also getting this super pulsed wave of 905 nanometers, which is sent in at 25 watts. So let's just make this clear. A class 3 laser, class 3B laser, is up to half a watt. Here we're sending in 25 watts, and they have another machine which will send it up to 75 watts. It just reduces the speed of time, but the power which is going in can actually make massive changes to the tissues in an incredibly short time over a wide area. So not only are you getting the reduction of inflammation and the tissue repair, but at exactly the same time, so it works like a triad together, you're getting the reduction of pain. You'll naturally be getting a bit of reduced pain just from the reduction of inflammation, but then you've got these pain pathways being inhibited by the 905 nanometers, and the therapeutic effect is pretty phenomenal. Just a little diagram to show you here. Here we have the frequenced pulse, which is what we're really talking about, the continuous. It's not totally continuous, it's frequency. That depends on the frequency which we're putting in. That's on the 808 nanometers, which is sent in at 1.1 watts. But then right through there, exactly the same time, is the 905 nanometers, which is sent in at 25 watts. Now, this does not cook you. It does not cause heat, which other lasers do, because what it's doing is it's super pulsed correctly. It's the only machine which is super pulsed properly to a nanosecond on, off, on, off, on, off. So the tissues heat, cool, heat, cool, heat, cool. I can show you diagrams, but with all research, they will never raise the temperature of the tissues above 41, possibly 42 degrees. You might feel a topical warmth, centigrade, whereas these other lasers you can get, which would send in the tissue, if you leave it stationary in one place, it will just heat up over 45 degrees, cause tissue damage and necrosis of the tissues, which is something you really don't want. Now, you'll see just below here, on this 808 nanometers, and I'll show you when we get onto the machine, it's CW, continuous wave. We can actually stop the frequencing and actually just get this going all the time, which you will see, just increase the joules which we're putting in, but it's not always beneficial to do this, and I'll explain why later. Okay, these are our different machines. This is a totally robotized one. I personally don't have it. I have this fantastic machine, which all this is this plus the Charlie head on our arm here. So you can actually do 2 pathologies at once or use them together to help each other on different settings at exactly the same time. More pictures of the machines. Right, now, ASA Laser, their approach is we do a global approach and then we do a pathology treatment. Global treatment or area mode, what we want to do is we want to actually treat all the tissues related to that problem that we have. On the Achilles tendon, we are going to be looking at the gastrocnemius, the soleus, possibly the perineal muscle, all the muscles around the area, because we want to get some photobiomodulation into the tissues to increase vascularization, to increase blood flow, and to reduce the tightness of these muscles. There is another thing which we can look at as well, is actually particular trigger points. And there's a fantastic little setting on here for trigger points. Okay, the machine will show you roughly areas. These are always a guide, so just don't go completely mentally exactly in this area. We're talking about all these tissues here. We'll go over the Achilles tendon itself, the perineal muscle, tibialis posterior is sometimes one which we can go over, but we'll be covering all those muscles when we do the scan. Here's a real looking, it says tendonitis, but this is a real tendinosis look where we have the thickening of the tendon. And this is where the MLS comes in. Yes, we can do our eccentric loading, but we want to speed this up and reduce pain. And with the MLS, we can do that enormously quickly, enormously beneficial to the patient. Okay? After having treated the contractures or the tightness of the muscles and quite possibly the pathology setting, it also wants to look at, looking at the pathology, but then looking at the trigger points. And again, I'll show you practically how we do this. Very, very simple and very effective. Okay, another nice picture. Trigger point in the tib post muscle. We will palpate for these trigger points, we'll find them, and then we'll treat them. And it's pretty astonishing how quickly you will get changes. You know, 50% improvement after just one 25-second or 20-second attack with it. This is the sort of stuff which you need to speak to Celtic about, getting lots of data about all the research which has been done using the MLS, and it's pretty extensive, but generally you can see here we have just a massive improvement in all these conditions. Average 97.8%. Okay, thank you. All right, let's go back to the room, stop the share, and we should be back in the room. Okay, right now, what I want to do is I want to show you the actual machine itself, or the software on there. Okay, so if we go onto here, and hopefully that's a relatively clear picture of the software here. Okay, on the machine, let's get our thing here. This is the screen which will generally come up. We want to deal with an Achilles tendonitis. Remember, we talked about doing the global approach first. We're just going to press on this area here. We are going to do a scan phase for the global approach, scan. It comes up automatically acute, but we can, if you have this a long time, if it's a tendinosis, it's generally going to be chronic. Now, I just want you to pay attention here. You probably see in the more acute pathologies, the settings here are great to go by, but we want to change this sometimes if we want a bit more in there. But you can probably see it's 300 hertz for an acute scan. If I go into the chronic, it changes, the hertz go up a bit. So generally, as a general rule, you can always think your hertz are going to be slightly lower in the more acute situation with a tissue like this, and slightly higher in a more chronic situation. it gives you straight away what we'll be doing, 4 minutes and 75% intensity. Okay. If I look across here, small, medium, large, everybody you see is going to be medium. Unless Martin Johnson walks in the room, then he's large, or a tiny little person comes in, then it's small. This another important area is the person white or black. I would say white really covers you know, your general Mediterranean color, whereas your dark Asian black skin, you use this. Now you'll probably see as well, this automatically changes everything for you, because on the white skin, 4 minutes, 75%, okay? When we go black, it's actually a slightly longer time, but decreased intensity. And this is all an effect, because has an effect on the skin, because you have the different types of melanonin coloring of the skin will take in the light more or less, depending on what the color is. So here we have a white person. We're going to say it's just an acute problem. And what we're going to do is we're going to scan. Now, what I will do is I'll just start it. Okay. You hear a little beeping, but nothing's really happening. And it only starts when I start pressing the button on the wand machine. We'll also go through using the Charlie head as well. So if I can just go onto here. Well, we've got a patient nice and comfortable there. Move that out of the way. I'm going to bring this in a bit closer so you can see quite nicely. What are we going to do? It was the left, wasn't it? We had the problem. Yeah, okay. We'll leave it down. We've got a nice bit of swelling around there. And we can probably see the leg down here. Right, now, I get my... oh, so many wires in here. Right, I get my wand. I'll bring it round. Okay. You don't start anything until probably the most important thing. Sorry? Most important thing, get the patient to wear the glasses, okay? This will cut out any reflective light. Obviously, if you shine it in their eyes, it's liable to cause some serious damage. But we've got the lights on, they'll fit over people's glasses. Very simple. And they're very easy to see through. But now we just get this down here on the ankle. And it'll only start once I press this button. If I do that, you can probably see now we get a bit of a red light tinge in there. This is actually not the laser light. This is just an LED showing you where it's going. Infrared light we cannot see. And that's what makes it so dangerous, and it can reflect off anything. So that's why we have to wear the glasses. Anyway, we're going to scan right round all the muscles connected with this Achilles tendon. And as pointed out, this will go on for 4 minutes. Now, just to save a bit of time, because I don't want to run out of time here, I'm just going to stop this myself. But what will happen is it will go on and it will just switch itself off. I'm going to stop it, okay? So I've stopped it there. And what I'm going to do now, I'm just going to go back to the screen on here. Okay. This would normally have gone right down to 0, okay, and it would have switched itself off. So I'm going to stop it here. But what we want to do now is we want to treat the pathology. So we're going on to the ankle tendonitis setting. We're probably saying this is a tendonitis. If it was a tendinopathy, I'd probably put a bit more power in there. Why? Because if it's a tendinopathy, it's a more chronic problem. So we could either raise the hertz, okay? You can raise the hertz by going like that, but it'll take you forever because it goes up at 1. So if I want to go 800 hertz, okay, and it'll just very slightly increase the joules. But we want to go a little bit more in here, get a few more joules in there. I'm going from 50% to 75%. You can probably see that's now gone to 9.84 joules per square centimetre. Okay, now what it's saying is 6 points over 7 minutes, which means we'll have about 1 minute, my maths is very, 1 minute 25 on each point, yeah, something like that. I'm just going to start it again. Nothing's happening, but let's just change this back to the other camera. And let's come around here with my glasses on, and then we say we've palpated around here and we found the pain is really bad around here. What we want to do is we want to get onto these points, but now we don't have to move it, we're just going to stay on here. So I've started it there, and you can probably see that the laser is actually acting there. And we're going to leave that for 1 minute 25 seconds. It will switch itself off. Really, 6 points, what we're talking about is really around the area which is really bad. So we'll probably have 2 either side and 2 on top of the tendon as well. So we cover the whole tendon area. I'm just going to let this first one go for the minute 25 because I want to show you it will switch itself off. It's amazing how long 1 minute 25 seconds is when you're waiting for it to happen. Patient, Francis, are you feeling anything at all?
No.
No. You see, right, switch itself off, and we're just going to move it around, probably to the other side here, and get it on, start it again. She's not feeling the heat because of the super pulsing at the 905 nanometers. It's pretty magic, but we're getting all this power into the tissues to make the physiological changes that we need to. So it's pretty amazing. After another 1 minute 25 seconds, it will stop itself again. I'm just going to stop it again. I'm going to stop it there. Then we'll probably go up around it, a bit higher up. 1 minute 25 seconds, it will stop itself. I can stop it any time. And up around here.
Sorry, Paul, to help you fill your 1 minute 25 seconds.
Yeah.
I had a couple of questions come through. How do you know when to increase the joules? Is it just experience, or is there a guidebook or similar?
Well, the guideline I tell you is if it's a more chronic situation, we can go up a little bit. We can change the hertz, obviously, if it's more chronic or not. That will actually affect the joules, but not too much. But the other way is to increase the joules. If we've got something which is really stubborn, very chronic, then we can increase the joules. It stops itself. I'm going to put it on there, on the top of the tendon. Experience. What I would always start with is a lower level with what they actually recommend on the software which it gives you, because there is always a danger. If you put too many joules into something, you will get what they term the rebound effect. And I mentioned this last week. The rebound effect is where they'll probably feel even a little bit more pain afterwards, or certainly within 24 hours, because you've upset the tissues. You've stuck in too much power into there, which there's no need to do. So start, or maybe just go up a little bit if it's more of a chronic situation. Increase the joules, increase the hertz very slightly. but don't go crazy, because these people at ASA, they know what they're doing and they've set it up pretty amazingly well. If you've got the person who comes in who's had this Achilles tendinosis for 10 years, bloody great thing there. I'd give them a bit more and monitor them from each time I see them, and probably decide to put a little bit more in if we're not getting the effects we want, because you will generally get the patient saying, wow, even after the first time, they'll feel a difference. And as within 24, 48 hours, they will really be noticing some sort of change. And on that basis, we also talk about the treatment quota we really want to look at is the quota of 3, 2, 1. Try and get them in 3 times the first week. Remember, these will only be 10, 15-minute sessions at most. You give them their other stuff to do, so you might be longer the first time you teach them what to do with their eccentric loading. But then 3 times the first week, twice the second week, once the third week. And you're going to get a massive change. Now, what we've talked about with a real tendinosis, it could take up to 100 days to really remodel this collagen totally. And your eccentric loading will do that. There's a problem though with the eccentric loading. I'm just going to stop it here. There is a problem with the eccentric loading, that being, let me get back in the room. Stop dressing like Bono. The problem with it is, as I said before, we're breaking down the tissues with an eccentric loading. A bit like if you're using, a shockwave, you're smashing the tissues, which tissues don't really like, and it'll cause an awful lot of inflammation. And that's how the shockwave works, through creating massive amounts of inflammation. Here, what we're doing is we are changing the cells at a tenocyte level, which is so much more important. And then if we're still using the eccentric loading, we can actually reduce the pain massively, just because of the setup of this machine with the 905 nanometers at 25 watts. So we can reduce the pain. So we can actually let them hurt themselves a little bit with the eccentric loading, but we can actually reduce the pain massively to make it much more possible to do. Hakan Alfredson did most of his research with elite athletes. So his recommendation, sometimes we have to take that with a little bit of a pinch of salt, because as I say, his protocol would be 3 lots of 15, 3 times a day. Remember, you've got to do twice as much of that, because you've got to do 3 lots of 15 with a knee extended, and 3 lots of 15 with the knee flex. Why? Because we're treating both the gastrocnemius and the soleus, which are going into that tendon, which is masses. And that is going to cause a bit of a problem, because you're going to get a huge increase of inflammatory problems. And what does this machine do? It decreases the inflammation. Hakan Alfredson would say to his elite athletes, he said, I don't care how much it hurts you, I want you to do this. And the only reason you can not stop doing this is if the pain is just so much, 10 out of 10, you literally physically can't do it, which is not something which we should tell our patients, because they're not all elite athletes. But we want to get as much of that going as possible. And we can get them to do this if we can actually reduce the pain massively, which we can with the MLS laser. I hope that makes some kind of sense.
Sorry,
right.
a couple of questions come through. To be fair, I think you've answered someone asking if the eccentric loading, would you do it after the patient's had all of their laser treatment or during the treatment program? You said do it together.
Well, you could actually, because it's not going to cost, you could actually, if you've got a bit of time, you could actually give them the laser, just the pathology setting, get them to do the eccentric loading, and then repeat the whole thing again, and just calm them down after having done the eccentric loading. But remember, I want the eccentric loading done daily, okay? And I want it progressive. So as they're able to do the 3 lots of 15 just off the step, I want them to stick a rucksack on the back and start sticking a bit of weight in there. because we're progressively doing this all the time. There's a thing called muscle memory. There's all sorts of problems like that. We just got to keep on changing it, because the big thing we're trying to do is we're trying to change the tenocytes. If you're just trying to change the tenocytes by smashing them and doing that, yes, it will work, but there's masses of pain. The other thing is these cells are sick. And what we're doing by using the MLS machine is we're actually making them better. We are oxygenating them. We are filling them with ATP. We are making these cells healthy again. So it might be a big round cell, but it's getting the ATP it needs, which will facilitate its repair through the eccentric loading so much quicker. It will make things so much easier. Right, now I just want to move on very quickly to using the Charlie head. Now the Charlie head, if I go back, I'm just going to show you what we can do here. It's pretty amazing, this. I want to go on that one. I'm going to go back on here. We haven't quite finished that treatment, but I'm going to stop it anyway. Let's say we want to really concentrate. We've got a real problem with that tendinopathy. If you've got the Charlie head, I tell you what I would do in this situation. I would go straight to a pathology setting here. Let's go back. So it's giving me exactly what it was. It's 700 hertz, 7 minutes, 50%, 6 points. Okay, and I've already shown you how I do that around that tendon. What I can do is on a completely different set. So I start that. Remember, it's not working until I press the button on it. But what I'm going to do now is, if you see here, I'm on this 1 or 2. If you just got the 1, you won't have this little button there. But I'm going to press on that, and it becomes the number 2. It becomes the Charlie head. You see, you don't have the scan settings. But what I'm going to do is I'm just going to go on here, and I'm going to go on ankle tendonitis. While we're here, can I just show you, these are the settings, this is what it's recommending, and I would stick totally with this. If you were really double macho and you wanted to really whack up the joules per square centimetre on here, a couple of ways of doing it. One is to actually increase it up to 100% there. It's gone to 13.48. If I was completely mental and this wasn't a really chronic situation and I wanted to whack that up even further, I just press this CPW thing, which means the 808 nanometers is going to be, instead of being frequent, is going to be continuous, okay? And by pressing on that, you'll probably see the frequency has gone here, but look what's happened to that joules per square centimeter, 27.41. Now we're talking some large amount of joules going into that area. You're most likely going to get a rebound effect straight away. So just don't do that. We're going to go back. So I've set the 1 for a pathology. Now with this Charlie head, I'm going on ankle tendonitis, and it gives you a recommendation of where we need to put this around there. But what I'm going to do is I'm actually going to go much more up on the gastrocnemius as well. So from here, I'm going to press start. And we're going to change camera angles now because we need to go back to the other camera. And what I'm going to do is, I'm going to bring this up here. Right. Now what I'm going to do here is I'm going to, first of all, I'm going to get my patient to put a glass on. She's got them on. I don't. I'm going to put my glasses on. I'm going to move this, the left ankle. I'm going to move this over here. I'm going to come 1, 2, 3 down on here. But then I'll be working all the time at the same time on that area. So now, to start this, I just press the button there, and you probably see that comes on there. If I move it around here, you probably see it's got a big coverage area. So we're on that there. The distance it should be is really, I can't remember if it's 20 centimeters, 15 centimeters. it's that distance, okay? So it comes with a little stick which comes out of it. I don't like sticking that into patients, and that is for optimum treatment. That's where we want to be. So I've got that going. At the same time, I come around here, and I'm going to get on here, back on this area here, and let's start this way, okay? And if I start that, you can probably see now, you see it's going, and it's in the tissues here. Now again, this Charlie head, it's got 3 points, it said. It's going to stop automatically when it's ready, and when it stops, it'll just switch itself off. I'm going to switch it off and just move it down to here. The other one's still going. They're on different parameters. They can, and we set it going again, coming down here. And let's say this one's stopped now, which it hasn't, but I'm going to stop it. I'm going to bring it over here, and I'm going to get working on that. Okay, what I would suggest with a patient as well, probably not the very first time because they might be in an awful lot of pain, but I would start getting them to actually start doing some active movement with this foot. Go up and down, okay? And that will help with the treatment. And I would probably consider that, if not at the second treatment, but certainly by the third treatment. And I'll go on from there. We are running a bit out of time, so I'm going to stop this here. Both of them. I stop that just by pressing the button. I can stop that by doing that. We can take our glasses off. What we do now is we get back in the room. So, three, two, one, back in the room. Okay, that is showing you how easy it is to use this machine. We can change the parameters. Just be careful. Just remember, in a more acute situation, it's usually lower hertz, higher hertz for more chronic situations, more joules for real acute, for real chronic situations. If we had the most stubborn Achilles tendon, which nothing had worked, then I might press the CPW and whack him full of joules and get the benefits from there. So just finally, just to show you how effective this machine is, I want to, it's not a case study per se, but there is an England rugby international, a fellow called Anthony Watson, a brilliant winger come fullback who ruptured his Achilles tendon 2 years ago. He had it reattached. He was in rehab. He was then having shockwave treatment. He couldn't really tolerate it, too painful for him, and also it didn't seem to be helping. And then he was doing some, as his training got higher, as he was repairing, he snapped it again. So this time he's got a really completely knackered tendon Achilles. Had it reattached, and then we got hold of him, and we started using the MLS laser on it. He loved it. In fact, it got him right back. It got him back to better than he's ever been. He's actually recording faster running now. He was back now this season and really at the top of his form. And he bought his own machine, I believe. I remember just before this lockdown, he'd had a medial collateral ligament injury, and he's just been using it non-stop every day on that and getting some great changes. What I just wanted to show you was, if we can come back here, I'm going to try and see what we've got here. What's that one? Right, now here we have this top international athlete, Celtic's very own Steve Sheldon, with Anthony Watson. Sorry, I got that the wrong way around. This is that top elite athlete, Anthony Watson, with Celtic's very own Steve Sheldon, at his house with his own machine. Here we've got the therapist using both the Charlie head and the wand at exactly the same time. It looks like he's holding the Charlie head. You can get an attachment to hold it, but in fact it's not. It's on a tripod. So if you're moving around, you can actually it's got a tripod fitting. You can fit it on a tripod and you don't need the whole system with the trolley and everything. Just finally, if this works, yeah, it's Anthony having the laser. Now what's going on here, you can see the tripod. He's got the Charlie head while the therapist is doing some other treatment at exactly the same time. So you've got a phenomenal usage of this. And I'd just like to point out, you can actually do the whole thing with just the Charlie head. Now, at this time where we've got social distancing, where we're going to have problems getting patients back because they don't want to be touched, and that's what we do, we can actually treat these people at a distance with the Charlie head on the arm, completely no contact. They're masked up, we're masked up. Anybody who's got the slightest bit of a concern, their concerns are gone because we are treating them with this amazing equipment at a distance. So that's it. I'll stop there because we are 4 minutes of questions. Phoebe, anything for me?
Yes, got a couple of questions lined up. Someone's asked, does the laser damage healthy tissue? You know, if you accidentally to shine it at the wrong place, it wouldn't make any difference.
Well, yes, yeah. If you shine it in your eye, yeah.
Well, yeah.
But no, there are contraindications with a couple of areas. One is on growing children. Don't stick it over the growth plates. What we're doing here, we're activating the cell at a cellular level. We're causing massive activation of the cells. I don't think I've actually specifically heard of any case where this has happened, but the theoretically, what they are worried about is that the growth plate being all activated and feeling it's come to conclusion, and therefore you'll end up with little Johnny with one leg shorter than the other because his growth plate is closed up. Theoretically, that is a problem. In practice, I've never heard of it ever happening, but I wouldn't try it. So I keep away from growth plates, but do I use it on other parts of them? Yes, of course I do. So it's really on the growth plates of the lower limb where we have problems. On somebody with an active cancer, we don't use it because what we're causing is cell activity, and in a proliferating, rapidly dividing cell tissue in a cancer, we don't use it there because, you know, I think it's unlikely you'd go down for it, but anything, you just don't do that. And the other area which I don't use it is on pregnant ladies. Now, I could be treating their shoulder. I literally do not treat the shoulder with the MLS laser because they can always say, look, if baby turns up with two heads, they could say, the fellow used the laser on me, and that has the effect on rapidly dividing, you know, of modifying the cellular tissue. Technically, yes, they're right. I don't use it, not because I'm worried about it happening, because it wouldn't happen. But if something like that did happen, I don't want them coming back to me 10 years later and saying, you know, Johnny's got two heads because he had the laser. And I'd get off, but I'd have to go through all the hassles of legal problems. But yeah, there are the little contraindications. We don't use it over a pacemaker because it can actually affect the electrical impulsing. But apart from that, it's pretty amazing. Things like diabetic neuropathies, massive effect, get feeling and increased blood circulation and get them feeling their toes again, working down the perineal nerve into the foot. It has so many uses, this machine. It is phenomenal. Any other questions?
Yes. With regards to using manual massage therapy with the laser, would you suggest doing it before or after the laser treatment?
I would do it after. The question is, what we don't want is too much. This laser has quite a big mechanical effect, and it will actually start starting vasodilation, everything like that. What we're doing with massage is we're actually really increasing fluid and movement around the body, which we want to a certain extent, but we don't want to overdo it when we're doing the treatment.
Oh, sorry, just one more bit more clarification. Did you say that you could use the laser, then the eccentrics, and then repeat the laser on the same treatment? You did, didn't you, earlier on?
Yeah, I probably wouldn't have done the scan first. I'd probably do the scan afterwards and probably just add a little bit more pathology, but I don't want to overload them with too many joules in one session. So I would probably give them the pathology setting, then so you're getting the cells activated, then start the eccentric loading, and then really definitely do the area mode over the, probably a bit longer and more intense over all the tissues around there, because you'll have tightness in that gastrocnemius, you'll have tightness in the soleus after having done the eccentric loading. What I was going to say about the eccentric loading, obviously that can't work because I want the eccentric loading done every day. And unless they're coming in every day to do their eccentric loading there, you can't treat them every day. But if you have the patient there, yes, you can do both at the same time.
Sorry, someone's just asked for clarification. If someone has a diabetic neuropathy, did you say that it can reverse it or temporarily?
We can actually improve it. We can't stop diabetic neuropathy, but we can actually. A lot of these people, they've never had any feeling in their toes for years, and we can actually make changes there. Interesting enough, in that area of well, it's a slightly different area, but I know ASA are doing lots of research on the use of this for fungal infections in nails. And so for podiatrists might be very interested in all that. And I know there is some literature which ASA have, which shows the effectiveness of this on the trials they've done so far on that area.